First of all, I would like to thank Dr. Santosh Shanavar and AAOS for giving me the opportunity to present the Neurophthal X-Files in Aishala. So today I'm going to discuss some of the important cases in neuroophthalmology which might interest postgraduates and which might be important for their exams. So there are certain important aspects of any neurophthal case. So first thing is history. History is very, very important to be noted for every case, because from the history itself, you might be in a position to come to a conclusion and come to a diagnosis even. So before we go into the details of every case, I would like to say is there are certain important aspects in neuroophthalmology which you have to give weightage, which are vision, which is the best corrected visual acuity in both the eyes, color vision in both the eyes, extraocular movements, pupil. Examination of the pupil is a very important thing, fundus examination, and visual fields. See, each one might give you a clue about what we are dealing with. So actually, I've taken some 6 cases, each one relating to either the vision, color vision, fundus, or pupil involvement, or extraocular movements. So we're going to discuss in detail. So when we talk about the history itself, so when vision, if you're calling that there is a drop in the vision, then you see whether the patient had a sudden drop in the vision. Was it a gradual drop in the vision? Or is it like a, was it associated with pain, or there was no pain? All that is important whenever you're dealing with any neurophthal case. So case scenario 1. So here we are seeing an young adult, 24-year-old, with a sudden painful loss of vision in the right eye. She says for the past 2 days, there has been a drop in the vision and she's complaining of pain. On examination of the right eye, the best corrected visual acuity in the right eye was just 2/60. And the color vision, just the first plate she was able to read. Pupil had an RAPD. So extraocular movements was full, but she said complaints of pain on ocular movements. Visual field, there was a gross field defect in the right eye. Fundus examination was absolutely within normal limits. Left eye was perfectly all right. Best corrected visual acuity was normal, color vision was normal, pupil was regular, reacting to light. Extraocular movements were full, the fields was normal in the left eye, and fundus was also normal in the left eye. So this is the scenario 1. So this is a fundus photo of the patient. If you look at the fundus photo between the right and the left eye, there's no difference at all. Well-defined margins, cup is well made out. There's no hemorrhage, nothing. So you know that this is an absolutely normal test. So you go ahead and examine the pupil. So what are we seeing? So you're doing a swinging flashlight test. So you're swinging the light from the right eye to the left eye and look at the pupil, what is happening to the pupil. So this patient has got a right eye RAPD. As you put the light onto the right eye, the pupil starts to dilate. So this is a right RAPD. So the probable diagnosis, sudden drop in the vision, pain, RAPD is present, fundus is absolutely normal. So field effects are like extensive. So you think in terms of right retrobulbar neuritis. So, okay, your diagnosis is right retrobulbar neuritis. What are we going to do next? So the first thing is basically we need to rule out a demyelinating disorder. Whenever you're seeing a young individual with an optic neuritis, especially a retrobulbar neuritis, basically we have to rule out demyelinating disorder, the most commonest being the multiple sclerosis. So when we order the MRI, what we are trying to look at is at the Dawson fingers. So these Dawson fingers are nothing but a periventricular plaque, which is around 5 millimeter in size, which are perpendicular to the lateral ventricles, and more than 2 is considered to be significant. Why diagnosing multiple sclerosis is important? Because basically, if it is a multiple sclerosis, you need to work in accordance with the neurologist to treat the patient, to prevent the patient from developing clinically definitive multiple sclerosis. So, and you will start the patient on ONTT, optic neuritis treatment trial, which is IV methylprednisolone 1 gram for 3 days, followed by oral prednisolone 1 milligram per kg body weight for the next 11 days, and fast tapering of the oral steroids. This is what you will do, and you will refer the patient to the neurologist to start the patient on interferon beta 1. So to prevent the clinically definitive multiple sclerosis. So case scenario 2. This is a young male, 25-year-old, having difficulty in reading with his left eye for the past 2 months. On examination, you find that the left eye had a best-corrected visual acuity of 6.6, and he required a small plus power, plus 0.75 for reading also. So the color vision was full, extraocular movements were full, fundus was within normal limits, And if you looked at the pupil was slightly more than dilated, and the patient had a sluggishly reacting pupil. The right eye was absolutely normal. So it's just the pupil abnormality was there. The vision and the color vision were normal, but the vision had a slight hyperopic shift. So we think what are we going to do is we are going to do the light reflex for this patient. So you see the pupil is kind of mid-dilated, and if you compare it with the other eye, definitely the left eye seems to be a little dilated, and you're putting a torchlight and looking for pupillary reaction. There's not much reaction for the light reflex. So what are you thinking of? You're thinking in terms of anizoporia. So anizoporia is when there is a difference between the size of the pupil between the two eyes. It could be physiological, it could be pathological. When you call it as a physiological, the size difference will continue to remain the same whether you're in a bright light or in a dim light. If it is pathological, if you move the patient to a brightly lit room or a dark room, dim room, then the size of anizoporia will increase. Then it is a pathological anizoporia. So the dilated pupil is well appreciated in bright light. Why? When the patient is in a bright lit room, what happens? The pupil has to constrict. If the pupil is not constricting, that pupil is the abnormal pupil. So the causes for dilated pupil and the patient having an anizoporia are going to be amerotic pupil, could be a traumatic mydriasis, could be a third nerve palsy, could be pharmacological. So in pharmacological, basically the patient will have a history of drop installation. And when you use a 1% pilocarpine, the pupil is not going to constrict because the receptors are blocked. In case of a third nerve palsy, along with the pupillary dilatation, you will have other evidence of third nerve palsy, like the patient will have a ptosis and the eye will be down and out and the ocular movements are going to be restricted. So you will exactly know whether the patient you are dealing with a third nerve palsy or not. In case of traumatic mydriasis, you will look for sphincter tears on the slit lamp and other evidence of trauma. And then we are going to deal with Aedes pupil also. Let's discuss in detail. So this is what we are rather seeing the patient. So when you look at the patient's pupil, you can see there is a sphincteric action over here and a sphincteric action over here. But the entire temporal region, there's no sphincteric action at all. So then you put the patient on the slit lamp and look carefully for vermiform contraction. What are vermiform contractions? Basically, these are worm-like contractions of the sphincter muscles. Here, if you look at the 6 o'clock position, once the light is put, you can see a fine constriction of the sphincter muscles over there, which is called as a vermiform contraction, which is very classical in Aedes. So what is an Aedes pupil? Usually, you have a large unilateral dilated pupil, absent a poor light response, vermiform contraction on the slit lamp, and near slow tonic contraction. Why does a near contraction happen? And it's a slow tonic contraction because the supply to the ciliary body to the sphincter pupillae is in the ratio of 30:1. And hence a slow tonic contraction occurs while the pupillary constriction is not that effective. And absence of deep tendon reflex in patients with Aedes is called as a Holmes-Aedes syndrome, which everybody knows is because of the dysautonomia. So the confirmation is by using a 0.125% pilocarpine, that is 1/8 of 1% pilocarpine is what you're going to instill. Wait for 10 to 15 minutes and then look for the pupillary constriction. If it is a normal pupil, it will not constrict. If it is because of Aedes, there will be a pupillary constriction because of the denervation supersensitivity. The ciliary ganglion, actually, the problem is that the ciliary ganglion and the postganglionic fibers, which are passed through the short ciliary nerves to the sphincter pupillae, is affected. And once the postganglionic lesion becomes denervation supersensitivity sets in, the pupil will constrict. So in a fresh Aedes, if you try this 1%, 1/8 of 1% pilocarpine, the patient's pupil will not constrict. Wait for a few weeks and then repeat the test. You will find that the patient is responding to the 0.125% pilocarpine. So basically for the treatment, if the patient is symptomatic, then put the patient on pilocarpine. If it is asymptomatic, you can leave the patient alone. So case 3, a middle-aged man, 55-year-old, came with the complaints of double vision for past 3 days, associated with pain, and there is drooping of his right upper eyelid. He's a known diabetic for past 10 years. So on examination, right eye best corrected visual acuity was 6.6, color vision was normal. On extraocular movements, there was a defective adduction, elevation, and depression, and the presence of ptosis was there. Pupil was well within normal limits, like it was round, regular, and reacting. Fundus was also normal. Left eye was normal. So when you're looking at the patient, you can make out very clearly that the patient has got a complete ptosis. On lifting the lid, the eyeball is down and out. And on checking of the extraocular movements, you can see the adduction is completely limited and the elevation is also restricted and the depression also restricted, stating that this patient has got a third nerve palsy. So the most important thing in a third nerve palsy is always to look at the pupil, whether it's a pupil sparing or pupil involving. If it's a pupil sparing, it's probably an ischemic cause. And if it's a pupil involving a third nerve palsy, it's a surgical cause. So you have to do a diplopia charting and a Hess charting. In diplopia, you will get a cross diplopia. And Hess charting is very, very important to know how the patient is progressing. So the investigations, basically the blood workup and BP, blood sugar and BP you will do. And you should always keep in mind about the giant cell arteritis, and ESR and C-reactive protein also should be worked up in an elderly population. And if it's a young person, basically imaging is very, very important, even though the pupil might not be involved in less than 10 years of age. Definitely MRI is indicated. And above 10 years of age also, always, if the pupil is not involved, also call the patient back again in a week's time to look for the pupillary involvement and assume that the MRI is absolutely normal. It's better to do a cerebral angiography to rule out aneurysm. Posterior communicating artery aneurysm is very common, which impinges on the third nerve and resulting in a third nerve palsy with the pupillary involvement. So basically, extension of the case 3, I would like to discuss this young man, 35-year-old, had a trauma and having been having a double vision for the past 3 years. On examination, you look at the patient, this is what the patient has got. The patient has got a partial ptosis on the right side. You look at the extraocular movements, the patient is moving his eyes. You can see that the adduction is full. On attempted adduction, there is widening of the palpebral fissure. And on looking down, there is a lid lap. So this is a clear-cut case of third nerve misdirection. So in a third nerve misdirection, what happens is a lid gaze dyskinesis and pupil gaze dyskinesis. In lid gaze dyskinesis, what happens? It is an inverse of Duane's. In Duane's, what happens on attempted adduction? There is narrowing of the palpebral fissure. Here, it is an inverse of the Duane's. On attempted adduction, there is a widening of the palpebral fissure because the nerve which supplies the medial rectus also supplies the LPS. And pseudogonographies happens because the nerve which supplies the inferior rectus supplies the LPS. This happens, third nerve misdirection happens only in cases of trauma or a compressive pathology where there is a misdirection of the nerve. In pupil gaze dyskinesis, you will have a pseudo-Urgell-Robertson pupil in which there will be a pupillary constriction on attempted adduction as well as in down gaze. Case 4, a young 30-year-old obese female with the early morning headaches with blurring of vision at times for the past 30 days. On examination, the best corrected visual acuity was 6.6, color vision was normal, extraocular movements were full, the pupil was round, regular, and reacting. But fundus examination showed a bilateral disc edema of approximately around 3 disc diopters and fields showed enlargement of the blind spot. So this is a patient's fundus examination. If you look at it, basically the disc margins are very much blurred and elevated, and you can see the patterns lines over here. And this is a screen visual fields. If you look at the blind spot, this is the blind spot, and around the blind spot, there is a definite enlargement of the blind spot here, as well as in this eye, you can see the enlargement of the blind spot, and few peripheral constriction field changes also have started in this patient. So the investigation, basically what you need to do is always think about malignant hypertension also. So BP has to be ruled out. It's a simple test, but we have to do in any patient with the disc edema, better to rule out BP. And then MRI has to be done to rule out any space occupying lesion. And then LP to look for the opening pressure. The opening pressure more than 20 centimeters of water should be considered to be having an increased intracranial hypertension if the MRI is absolutely normal. So assume that this patient had an increased intracranial hypertension. She was an obese young female, had polycystic ovaries, and very classical patient for a benign intracranial hypertension. So basically, what is the treatment option you can give is the weight reduction, and the patient can be put on Diamox, and serial OCT of the disc can be done to know exactly whether the swelling of the optic disc is coming down or not. So on Diamox, if the patient is responding well and good, no problem. If the patient is not responding to Diamox, then probably we'll have to think about an optic and shunts. Case 5, it's basically a left eye painless loss of vision 624 vision, and superior sectoral disc edema was there. Just 2 more minutes, I'll just complete. Inferior altitudinal field defect. And if you see, there is a sectoral disc edema. And the other eye, you can see a small disc. So your suspicion should be, and the field is also showing a typical inferior altitudinal field defect, suggestive of non-atretic AAON. Another patient, young female, bitemporal hemianopia, you should always think about in terms of pituitary adenoma. So the nasal fibers are involved, and hence you will get a bitemporal hemianopia. MRI and endocrinological workup and neurologist opinion is needed. Thank you.